Judy. Good afternoon, everybody. It is a great personal pleasure to be addressing a room full of journalists. You are the key to helping to create and inform civil discourse in our nation. You better than I know that journalists are fundamental to solving society's problems, helping us solve our problems, and enabling us to talk together on important areas where too often we become polarized and enter into very divisive language. Today we are focusing on one of those areas, end-of-life care. It's an area that's easy to misunderstand, as Judy just said, and from time to time, not always, and not earlier, but more recently, become unnecessarily polarized. End-of-life care is not a Republican issue or a Democratic one. It's not a religious or a secular one. It's not even an intergenerational one, because we all die at all ages. 50,000 children die in the United States a year. It's an inevitable part of the human condition, and we need to have a more adult conversation about how to manage it. So that's why the Hastings Center proposed to have this three-part workshop, this half-day workshop, separating fact from fiction, and we were thrilled when the Association of Healthcare Journalists accepted our proposal. The Hastings Center was started in 1969. It was a time of enormous explosion in biomedical innovation, new technologies that were raising all sorts of questions that we had never had to think about before. Questions like the one that Karen Ann Quinlan's father asked: would it be killing to turn off your ventilator? And I'll be talking a bit more about that case in a moment. There were also scandals like the Tuskegee syphilis study, in which African American men were denied the use of antibiotics for decades after it was available. Scholars at the Hastings Center have been writing about these issues for 45 years. We've been publishing about them. We have 2 journals. And we enjoy being an independent, nonpartisan source of reliable information for you, for journalists. Last year we had about 160 inquiries that came in from the media, and we see it as an important part of our mission, not only to do scholarship, but to serve the public, and most effectively that means working with and through experts like yourself. I'm going to talk first for about 15 minutes about the ethical and legal framework in the United States for making these kinds of difficult decisions. So I'm going to be sort of the part of this panel that's framing what exists and where there is a preponderance of agreement, not absolute agreement, but a preponderance of agreement about the help that we can find and the approaches we should take, what are helpful guidelines for thinking about the difficult decisions that we face. We're able to do this because back in 1987, we published a landmark document called Guidelines on Decisions about the Use of Life-Sustaining Treatments and Care Near the End of Life. That was back in '87, and it helped to form the foundation and the norms that are in hospitals and healthcare settings today. Whether or not clinicians realize that, it was at the origin of how these decisions are often approached in current healthcare systems. Last year, under the leadership of Nancy Berlinger and her co-authors, Bruce Jennings and Susan Wolf, and with funding that we were very grateful for from the Donahue Foundation in Connecticut, we published an updated, enhanced version of those guidelines, a new edition, which we have information about over there. So my part of this presentation is to sort of tell you at a very high level some of the keystone principles that have guided this framework that you can learn more about over there. And I'm going to finish up by just saying a bit about where we're located in case you want to follow up with us. This is the mansion that we occupy in Garrison, New York. We're an hour north of New York City along one of the most beautiful train rides in America, the Central Hudson River Valley. Don't be angry with me for the next slide. This is the view from my office. And rather than being angry, come and visit us. We always have an open door. We have 2 apartments. Usually they're visiting scholars from around the world, but we would be delighted to host journalists as well. So when I was thinking about how I would spend my time with you, how to summarize something as elaborate as the guidelines volumes that we've produced, I thought I'd best tell it through the story of Brian. Brian is somebody who ran up to the lectern after a talk that I had given, and he kind of grabbed my forearm and stared me in the face, and I remember that he had really bright blue eyes, and he said after my talk, "So you mean they didn't have to do that to her?" He was talking about his grandmother. She had suffered a stroke. She had some cognitive deficits and some physical impairment, but she could still signal pleasure and displeasure. And she still recognized Brian and his parents. And she seemed to appreciate their visits to the nursing home. But then she had a second stroke. And this time she lost her ability to speak or to swallow, and a feeding tube was placed. Ultimately, Brian told me a tale of increasing dementia, fear, and unhappiness. His grandmother got pneumonia several times, and each time she was sent back to the hospital, which only caused her dementia and confusion to grow, which is often common with frail elders as they move out of familiar settings into a hospital. As the weeks passed by, his grandmother was conscious less and less, and in the few times when she was awake and he was there, she would shake her head. He began to feel that returning her to the hospital over and over again was a kind of torture. He and his parents were on the same page. They approached the nursing home and they asked that the next time she developed pneumonia, that she not go back to the hospital, that she be allowed to pass. The nursing home administrators were appalled, and they refused the family's request. And then, in Brian's view, things got even worse. His grandmother's kidneys failed, and the nursing home referred her for dialysis, despite the fact that she was unconscious most of the time. Now, I think reasonable people might arguably disagree about what was in Brian's grandmother's interest, but the problem was that she never got any kind of advance notice of what she herself would have wanted, and this is the kind of quandary that many of us and our parents will be facing. As I was telling that story, how many people were reminded of somebody in their own families. In the span of a short 50 or 60 years, human beings in the developed world have transformed the death and dying experience. We used to die from infectious diseases or sudden accidents. And now, because of modern medicine, we live longer, but with chronic illnesses that progress very slowly to death. And so death is an indeterminate matter. Now, obviously, we're probably all very happy that we were born into an era with amazing medical technologies because they bring tremendous benefits. But they also are a kind of Faustian deal. They pose real quandaries. Often these technologies, as you know, are called halfway technologies because they can't restore the underlying condition. And they are deeply personal questions, which can only be resolved ourselves and with our loved ones. In the United States, and through the guidelines that I mentioned when I started talking, we've developed a framework for helping to think about this. But one cornerstone of that is how deeply personal these issues are. Patients have the right to forego all manner of interventions, from the most complex to the simplest, but there has to be a process in place to have those decisions be made. So what I'm going to do is describe that framework now through the lens of the two most paradigmatic cases which help to establish it. And then I'm going to pass the baton to Professor Meisen. So the first case came to the attention of Americans in 1976 with Karen Ann Quinlan on the cover. And this is a closer and better picture of Karen Ann Quinlan. She was a young woman in her 20s who had a hypoxic event, so she was without oxygen for so long that she ended up in a permanent irreversible unconsciousness in a persistent vegetative state. Her parents believed that she would not want to be maintained like this, and they asked the doctors to turn off the ventilator. The doctors were not opposed to that, but they were worried, would this be killing and would they be liable? And so they asked the family to seek court support for this decision. It eventually makes its way to the New Jersey Supreme Court, and the final decision basically puts it this way. The way to think about this is, imagine that Karen herself could wake up, be up on the ceiling, look down at herself on the bed. What would she herself want? Deeply personal question, wanting to honor the choice of the patient. And who would know best? Certainly her parents were presenting themselves as the people who would know best. That would be the right decision. And so the court enabled her father to have the authority to withdraw the ventilator. This case established that patients have the right to forego unwanted medical treatment, and that that right is preserved even after they've lost decision-making capacity themselves through the people who are closest to them who can think about how the patient themselves would have wanted it. So that was established in the first case. But then there were lingering questions. What if it was nutrition and hydration and not a ventilator? What then? The next case that helped to examine this issue went finally, ultimately, to the US Supreme Court, and that was the case of Nancy Beth Cruzan. Again, a woman in her 20s, again, a hypoxic event, again, persistent vegetative state, again, family asking for remedy, asking the physicians to cease and desist. The response to this case reaffirmed from the Supreme Court, reaffirmed that patients have the right to say no, that that right is effectuated even when they've lost capacity through the people who know them best. And it also validated that this is true for all kinds of technologies, no matter how complex, including artificial nutrition and hydration, which was the technology in question in the Cruzan case. However, it was also a complicated case because it was, in a sense, a states' rights case. And Missouri had a higher evidentiary standard for determining whether we really know an incapacitated patient's wishes or not. And so the case went back to the Missouri courts, where the family was obliged to be able to provide evidence that they knew what she would have wanted. They produced that evidence, and ultimately, Nancy Beth Cruzan was allowed to die. The third case is Terry Schiavo. And that's more recent. I'm sure many of you followed it. I'm not going to talk about it in detail. Simply to say, there really wasn't anything new about the Schiavo case. It was very similar in its architecture to the two cases that I've just described to you, particularly to the Nancy Beth Cruzan case, because it was also involving nutrition and hydration. So it didn't really break any new ground. And it's not surprising, therefore, that all the courts, as it made its way through the state of Florida, continued to uphold the right of her husband to make these decisions, and that it came out very consistent with the framework that I've just been describing to you. But what happened was that it became politicized. Now, back in the middle 1990s, this was not a partisan issue. The Patient Self-Determination Act, which says that all patients entering healthcare facilities should be told of their rights to have an advance directive, was sponsored by both a Republican and a Democratic senator. As I said at the start, this is not a Republican or a Democratic matter. But the Schiavo case became a cause célèbre for certain political interests. And one of the sad things that happened is that the way it was reported in the media introduced confusions. For example, I did an analysis of what was going on the internet. And here, for example, it was described as a major euthanasia battle, when a decision to withdraw a life-supporting technology is not in any way an example of euthanasia. And you can see this in other headlines. Assisted suicide and euthanasia become issues in the Schiavo case. False. There was no issue about physician-assisted suicide or euthanasia in this case. So, to summarize, the broad consensus where there's a lot of agreement is that foregoing treatments is not the same as assisting suicide, or what we would say today, aiding dying. Patients can choose to forego treatments, all types, from the most technological to the simplest, like antibiotics. Families can decide on behalf of incapacitated patients. The key is to assess the relative burdens and benefits of the proposed decision as the patient would perceive them, And so quality of life considerations are seen as appropriate, but only as the patient would assess them. While families and patients have preeminent authority, this right is not absolute, and that third bullet is something that Professor Liza will talk about. The right to refuse treatment does not imply a right to demand it. So that has been a framework that has been upheld since the middle 70s, but there are still a number of unsettled questions, and so at this point I'm going to stop. Well, I'll take questions after Alan gives his part of the presentation.